I'm so thrilled to be able to join you for the Scientific Symposium, the 20th, to be able to be with you virtually in Hong Kong. We are filming here from Mexico City, from the Mexican Health Foundation and Tómatelo, Pecho. Again, I wish I could have been with you in person, but I'm tremendously honored to be able to share with you via video a presentation about how breast cancer is changing the way we think about health systems and how breast cancer is truly a challenge for global health. I'll be sharing with you a panorama that goes from the personal experience on through to an analysis of breast cancer globally, and then to some of the innovations that we've been able to put forward in Mexico, and a few of the implications that this might have for thinking about working around breast cancer in the Asia region. Let's proceed now to the presentation as we go to our first slide. The entire presentation works with you around the idea that there is a duality between evidence and advocacy. We would like to have evidence-based advocacy, which I know is something you are all working on from the NGO and civil society community, but we would also like advocacy-inspired evidence. When we have these two working closely together, we have much more efficacious action for patients, for projects, for programs, and for policy. This is the framework that we're going to use. Let us start with the advocacy component that usually begins with personal experience, and in this case, let me share mine. This is what I was looking like in June of 2007, and I'm standing in front of a very important painting, one that was painted by our 11-year-old Hannah. She's now 19 and studying medicine here in Mexico. At the time, she was 11. But Hannah painted at that time a very important and sensitive age, which she saw at that moment as the life of her mother, the energy of her mother, and it all came from her hair. Yet, only a very few months later, I found myself in our family, there with our younger child, Mariana, age 3, facing a diagnosis of invasive breast cancer with no prior history. I was diagnosed on my first baseline mammogram at age 41 in a small primary clinic, and if anything, that saved my life. Now, the journey that we've taken with this disease has moved us through what often happens with a relatively young woman, in my case, diagnosed with invasive breast cancer. Multiple surgeries that eventually ended up with a mastectomy, 16 rounds of chemotherapy, a year of trastuzumab, 3 years of other adjuvant treatments, 5 years of tamoxifen, and now we're at that survivorship stage where I live with the sequela of all of that treatment. We'll look at that survivorship phase, which I know is also very important to women in Hong Kong, when we get to the last part of the presentation. But what I wanted to share with you with the personal story is not only what I faced with my own treatment, that I know that many of you who are there in the audience have also faced, and probably some are facing. It's how did we deal with this? What was the family way of dealing with this? And part of it, as you see in this photo with our little one Mariana, is that you laugh in the face of the disease. And we did that. We worked at it as a family. And we found out things that, for me, were jokingly funny. This is my brother, who actually flies with the Canadian military. And I had always assumed, because we looked so different, normally, that we weren't related, that somehow we had come from different families. But you know, he in the military, me, almost bald, I could see for the first time in my life that we truly are brother and sister. And so you find out things when you look at them a different way, as we saw in this family photo. I lived this disease with my husband, who when I was diagnosed had just finished 6 years as the minister of our Mexican Ministry of Health, the Secretary of Health. He had just spent 6 years leading a health system, and we lived this as a couple. He got into that bed with me, and we learned how to live a health system with a chronic disease. We've spent the last years, since 2007, reliving and relearning health systems to understand about the chronicity of disease and how patients face that. And that's a lot of what I'll be describing to you, going back to the evidence now, and bringing it to you in light of some of the work that we also did with the Global Task Force on Expanded Access to Cancer Care and Control. So now let's leave that personal story that's actually transcribed in a book called Beauty Without the Breast, and go to some of the academic work. This is a scientific conference. Let's go from the advocacy now to the evidence, from the anecdote to the scientific. The work that you'll see that we put together really is a combination of global health and work on cancer. It's what we call a diagonal approach. It's also the work of many different commissioners, some of them are pictured here, who worked for many years to produce Closing the Cancer Divide, and a whole series of ideas and activities led by many, such as Princess Dina Miret of Jordan, some others, Julio Frank, Rifat Atoun, Peter Piot, Mary Gospodarowicz, who is the Chief Medical Officer in Toronto Prince Margaret Hospital, and of course Paul Farmer, a leading global health figure, thinking about the links between global health and cancer. The work itself, Closing the Cancer Divide, looks at the equity aspects. It thinks about 4 different myths that have to be broken down. That it's unnecessary to do anything about cancer in developing countries because it's not a health priority. That it's unaffordable even if it were to be necessary. That it's impossible, too difficult to do anything about it. And that even if we could do all of those, that it's inappropriate because we have other diseases that the poor face. We break down all of those myths one by one, as we'll do in this presentation, and we see that it should, could, and can be done. Let's look now first at why this, in fact, is, without any question, a global health priority and a necessary health priority, something that we have to strive to change, close the cancer divide, also because of the equity aspects. So, and we're going to look at this through the lens of breast cancer. We could have taken many cancers. We're going to use breast cancer in light, in particular, of what I know is the topic of this conference. The cancer transition is a double burden for health system. It mirrors the epidemiologic transition. Low and middle income countries are increasingly facing both infection-associated cancers and non-communicable cancers. And you see that very clearly with women's cancers. Cancers that are increasingly only of the poor are not the only cancers that strike the poor. When we look at the case of women's cancers, low and middle income countries account for well over 90% of cervical cancers, but in addition, more than 70% of breast cancer deaths. Cervical cancer is an infection-associated cancer. Breast cancer is a non-communicable disease. Both are leading killers, for example, of young women. What are some of the major numbers around breast cancer in our world? It is the most common cancer woman globally and the second most common cancer overall. We are diagnosing approximately 1.7 million new cases every year. That's 4,650 women per day in our world. We have 4.8 million women living with breast cancer, those who are being diagnosed. More than 520,000 deaths per year, 1,450 deaths per day. It is among the top 5 causes of death among women in middle-income countries. And we know that, for example, in the United States, 1 in 8 women will have breast cancer in her life. This is a huge global health problem. It is also different when we look at high-income populations and lower-income populations. These graphs, these pie charts, look at age of diagnosis in the upper quadrant and age of death in the bottom quadrant. In low-income countries, and here we also show you Latin America, somewhere in the middle, the majority of diagnosis and of death is happening in women in premenopausal stages of her life, before age 54. In high-income countries, it's only a third. So the way that this disease plays out in younger populations and poorer populations is in fact different when we look at the profile around the world. That's why, what we've seen to date, we are saying that this is a health priority. Now I want to say something about why it's an equity priority. It is a priority because cancer today, breast cancer is our tracer, but cancer overall is a disease that strikes both poor and rich. But it strikes the poor in different ways. Exposure to risk factors tends to be concentrated among the poor. Preventable cancers, those associated with infection, are much more common among the poor. Treatable cancers, both deaths and disability, concentrated among the poor. Stigma and discrimination among the poor because we don't have the institutions, the laws that protect our patients. And avoidable pain and suffering, one of the most serious divides. If you look across countries around the world at the opportunity to survive breast cancer, we have low-income countries here on the left going to higher-income countries on the right. A woman diagnosed in a low-income country has only half the probability of survival that a higher-income woman would. In other words, the probability measured as mortality over incidence is 1 in 2 among low-income countries. It's 1 in 4 in higher-income countries. When we look at that type of a descending line, we can develop an idea of what could be avoidable mortality. That if we were to implement some of the most basic of interventions around earlier detection and just the basics of treatment, how much flatter could that line, that inequity of survival be? And one way of looking at it is in the following numbers. It's the percent of deaths that are considered avoidable if we had more support in earlier detection and treatment. We're looking at a figure of somewhere around 40 to 60% in our low and lower income and upper middle income countries. And even in high income countries, 20 to 30% are in fact considered avoidable. When we look at this around the world, 75 to 80% of breast cancer deaths are in fact avoidable. Were we to do better early detection and better treatment, that's a huge mass of women that we could be saving. The good news, when we look at recent patterns, and here we're looking at the United States, is that we are really finally seeing a decreasing line in terms of mortality. The pointed lines, the broken lines, are incidence. The solid lines are mortality. Among all groups in the United States, we are in fact beginning to see a decline. There are inequities, but mortality is going down, even though incidence, as we would expect, continues to rise. So that's the global picture. We've tried to show you that it is in fact absolutely necessary to do something about cancers and about breast cancer, and now I want to look at whether or not it is affordable to do so around the world. We studied this as a group. We were able to show that all but 3 of 29 high-priority cancer drugs were off-patent, that pain medication is cheap, that prices have dropped tremendously over time. Here we documented hepatitis B and the HPV vaccines. And that if we could aggregate delivery and financing innovations, we could reduce prices tremendously. So we have a situation where the cost to close the cancer divide may be far less than what many fear. Furthermore, we see that the costs of inaction are huge, and that investment in action is clearly what we need. Tobacco, the obvious example, a huge economic risk. 3.6% reduction in GDP globally per year. Our estimates around cancer overall show that it's taking up 2 to 4% of global GDP. We also show that overall, 1/3 to 1/2 of cancer deaths are avoidable. That's 2.4 to 3.7 million deaths per year, of which 80% overall are in low-income countries. And finally, we showed that prevention and treatment, just the basics, not the fancy stuff, would in fact imply potential world savings of between $130 and $940 billion. We also know that we have champions around the world, and that we can think of an economics of hope, that if we were in fact saving lives more, we would be developing individuals and their ideas. I take some of our global leaders here to show you. The president of Harvard University, Drew Faust, a 25-year survivor. Amartya Sen, my mentor, a Nobel Prize winner, diagnosed at 18 in India with hard palate cancer. Had we not invested in these individuals and their treatment, all of the incredible ideas that they've generated would never have come out. That's the economics of hope, and that's what makes investing in cancer care and control globally even more of a good investment. So that's a brief overview of the ideas around it being affordable. Now let's look at why it's appropriate and go back to the issue of women and women's health. This figure traces out what is happening globally in terms of why women die. For mothers in low and middle income countries, adult women, you're seeing here on your figure that there's a 30% reduction in so-called maternal mortality. Move across the figure. Globally, many more women at this age are dying of breast cancer, cervical cancer, and diabetes. The message here, however, in this figure is not to invest only in cancer and diabetes. It's still unacceptable to see women dying in childbirth. But in fact, what we'd like to see is a life cycle approach, one that takes into account all of the different needs of women around the world. That's why our Closing the Cancer Divide applies a diagonal approach and a life cycle approach that looks across the lives of women and patients. And when we apply this, as we do, you get to a very different procedure in looking at how to strengthen health systems. You take a diagonal approach, one of the most innovative ways of looking at health system strengthening. And it says a diagonal approach, don't look only horizontally at strengthening health systems. Don't look only vertically at a specific disease like cancer. Look at the synergies across the different interventions, and therefore the outcomes are more than the sum of the parts. That's what I want to share with you now as we look at the different ways that we can apply diagonal approaches, using examples from breast cancer in particular, to solve this global cancer divide. Here are a few examples. Positive externalities. Promoting prevention of healthy lifestyles. It reduces risks for cancer, but also for many other diseases. That means that any intervention that promotes healthy lifestyles is in fact being applied across many diseases so that the cost-benefit ratio, in fact, goes down. Your intervention becomes thought of as more beneficial and less costly. That's what we want when we want to sell important interventions to our ministers of finance, for example. Take another example, which is reducing stigma for women's cancer. It contributes to preventing gender discrimination. Hugely important. It also invests in treatment and produces champions, as we saw. These are additional outcomes that makes it easier to explain from a financial point of view why investing in treatment and promoting the cause around women's cancers, and particularly breast cancer, is so beneficial. Now, there's a worldwide wave of reforms to achieve universal health coverage. And universal health coverage, in fact, talks about everything along the spectrum: prevention, promotion, treatment, rehabilitation, and palliative care, without risking impoverishment. What does that have to do with the way we think about breast cancer? When you take a continuum of disease approach, as we have to do with a chronic disease like breast cancer, you need to look at the 6 stages of the disease: primary prevention, early detection, diagnosis, treatment, survivorship, and palliative care. And you need to do this in the context, if you are a health minister, of thinking about 4 health system functions: stewardship, financing, delivery, and resource generation. This is a very complex model for our health systems. And this is what we're trying to see and show you in this graph. A health minister who wants to think about how to treat the issue of breast cancer must think now across all health system functions and across the entire spectrum of what this disease is. All 6 steps of the disease process, much more complex. Now, how does the diagonal approach help us to do this? Let's go now to specific experiences in Mexico that generates and shows why it's appropriate and also possible to do something about this disease. Taking the Mexican case, I want to first look at financing. Recently, as recently as 2003, a major health reform came into. In 2007, breast cancer was included in that health reform. What's happened is we've seen a diagonal expansion along populations, the horizontal, and along the vertical coverage, which is the entitlement package. And we've seen a tremendous increase both in affiliation of beneficiaries as well in benefits over the last 13 years, as described by these figures. And that's why we can say in Mexico that in terms of entitlement and financial protection, we say we've reached universal health coverage. But the cancer picture here is specifically, and very important to understanding this. Our Seguro Popular, a national health insurance, now includes cancers for all. And it was a rapidly accelerating initiation where we were actively putting into our catastrophic fund different cancers. Beginning in 2004 and 2006 with cervical acute lymphoblastic leukemia in children, as I mentioned, breast and other pediatric cancers in 2007, and it's continued to expand. This is a way of thinking about a diagonal approach that includes cancers. That's one way of seeing success. I usually show success with the human face. I show success, as we see, with numbers for a National Cancer Institute, where we now show that whereas in 2005, before there was national health insurance, we were losing about a third of patients in the first few weeks. And by 2010, some recent data, many more patients, and we were losing very, very few to lack of funding to pay for the treatment. I met some of these women. I've gone around our country meeting them. This woman, a wonderful woman, Guillermina Avila, suffered a recurrence, but spoke to me about how important it was that now, with her coverage, her financial coverage, she didn't have to ask her children to sell their businesses a second time, to impoverish their families to pay for her treatment. That's when we look at the success of a financial diagonal approach, as is a Seguro Popular. That's the good side. Now let's ask, is it working in terms of saving our women? When you map out mortality in Mexico, you see the delivery failure. In Mexico, we have rich states in the north, poor states in the south. Unfortunately, you're about 5 times more likely to be late detected for breast cancer if you live in the poor south than the wealthy north. We also have statistics that really truly make me shiver, like that it is the second cause of death, breast cancer, for women aged 30 to 54 in the country that I call home. The delivery failure is what we have to look at in finding solutions. And that is, in fact, what we've done. We've developed for Mexico a capacity building program that began with community health workers. We've now trained thousands around the country, and we've been able to show in a paper published with a colleague, Nancy Keating, from the Harvard Medical School and the oncologist, significant increases in knowledge, especially among health promoters and in clinical breast exams. This is a significant increases that sticks. That information has stayed with our health promoters, and it's led us to write and believe that community health workers and health promoters can be hugely important in the battle around breast cancer. We've gone on to show how those kinds of community and capacity training initiatives that we've done with the National Institute of Public Health in Mexico have to be expanded to include the survivorship phase and to include the pain and palliative care phase, something that we saw here in a visit to a hospital in the north of our country. Out of that, we've developed a new commission, a Lancet commission, on access to pain control and palliative care that takes, again, a diagonal approach and looks at how strengthening health systems is crucial to improve palliative care around the world. We've gone on as well to analyze the survivorship phase, which I know is very important in the Hong Kong community as well. Here we've looked at it in the case of Mexico for young women. We've in fact asked these young women with breast cancer, what are the aspects that are generating for you fear, limitations, and barriers? And they speak very openly about uncertainty surrounding fertility, body image perception challenges, employment discrimination, loss of social networks, and unmet primary and psychiatric and psychological care needs. The survivorship care aspect, as well as the palliative care aspect, are areas where I feel that we are just beginning to be able to do training for our healthcare professionals and guarantee access, in fact, around the world. We've looked at the fact in Mexico that we need to educate our policymakers to understand that with interventions like the Seguro Popular, more of us will survive and will survive longer. And therefore we have to integrate survivorship care into our policies, into our entitlement packages, into our social insurance, and in order to be able to guarantee that women like myself, who will live with the sequelae of our disease for many, many, many years, we hope, will have to have the sorts of treatment that were not clearly available to because we have never done the capacity building for our healthcare workers to be able to offer these. We've begun a new round of training, now with over 10,000 of our physicians and nurses in our Social Security, similar to the training that we did with community health workers. But what's particularly interesting, and I wanted to share it with you here, is where our physicians and nurses are not doing well is on survivorship. Somehow we have not been able to train them to get the materials across. Again, it's where I think we need a tremendous amount of work, and it's a hopeful area of work around survivorship, around improving the quality of life in all aspects of life of our many women who will live with this disease, with cancer. And I want to close now with this last slide, because what we have been doing over the last year or so, particularly from Harvard University, working with Komen, now working with where I'm based, as of now the University of Miami, as well as Mexico, our National Institute of Public Health, my NGO, Tómatelo, Pecho, and the Mexican Health Foundation. We've been working over this past year to try to look at how our materials that we developed, applied, and piloted in Mexico could in fact be of interest and use in China and of course in Hong Kong. These are some of the results of adapting those materials for China that we did in 2014 and 2015 with support, again, greatly appreciated from Komen. We look forward to be able to doing more with many communities, and we hope to be able to continue to do so again and in the future in Hong Kong. And I close, as I usually do, and prefer and love to do, with this last slide, because it speaks to me, someone who lives with this disease, someone who's lived the treatment. It speaks about what it means to do work on cancer in low and middle income countries. You have to be an optimist and you have to be an optimist. But the picture tells a special story for me. I actually managed to get septicemia in my very last infusion of chemotherapy, when we thought I was around the corner and all was going to be well. As many of you know, septicemia is very serious. It could have been the death of me. And that morning, when I was shaking with fever, and I left my house and I said goodbye to this child, I wondered if I would come back. It was the only time I really ever wondered that, because cancer isn't something where you don't know if you're going to come back that day. You think about it in the longer term, you have a longer battle. Septicemia was that day. And yet, with appropriate support, our great hospitals in Mexico and wonderful physicians, within a week, and with a little bit more surgery, as you may be able to see in this photo, I was a week later with that same little child, with their lovely Mariana, in Canada on vacation and in a butterfly farm. And in that butterfly conservatory, what happened was that I became a very popular, bald, cancerous mother. I have to say that it wasn't always attractive to her to have me bald, to have me with a hat, but with these butterflies all coming towards me, all thinking that there was something special and beautiful about being bald, I became wonderfully popular and a focal point for this small child. And it was a moment in which I was able to turn around what could have been such a horrible experience, moments of tremendous fear, of difficulty, of difficult treatment, into moments of hope. And I think that that is what we face, and that's what we have to face when we look towards doing work on cancer, and breast cancer, among poor populations, and in fact with women more generally. It's what has to inspire us. It's those moments of beauty. It's this hope for what we can be. And it's the fact that infused by what cancer can teach us to be and to do, we can do so much to help so many and to strengthen our own health systems and to promote the health of women. Thank you so much for giving me the opportunity to share with you, to be part of your scientific symposium this year. I hope soon to be able to see all of you in person and to again be able to collaborate in the wonderful, incredible work that you're doing in Hong Kong, both on advocacy and on evidence.